So yeah, I hope I have been sharing the right things until now, otherwise I'll cry. But yeah, we'll see. Time will tell. But for the most important bit, I'm sharing the right thing, which is your case study document. So I have double checked that. And yes, it is your case study document. So now we'll commence. All right, guys. So your today's case study is on weight management. And when we talk about weight management, it is not underweight management, it is overweight management. All right. So we are talking in terms of overweight and obesity. Okay, so yes, so let's go through the case study. You have a lady, her name is Kalinda, female, 26 years. She has been referred by her GP specifically for weight management guidance and advice. This is again, as I said, this is my practice of writing, which is that the patient is not hypermetabolic, the patient is outpatient. So that's just me being more pedantic, but this is not required. Then, what are the social factors? She lives with her partner. She has a 3-year-old daughter in Punamula. I guess that's how it's spelled. Okay. So it's 9 hours drive from the Gold Coast Hospital, and her parents and her younger sibling, two brothers, they live in the same town with her. And it's not reported who cooks, but right now we can assume that she is the one who does the cooking, but obviously if you had her in front of you, you would ask her this. Kunamula is a remote rural sort of an area, and therefore there may be some geographical issues in accessing food at the same price, accessibility, availability issues that aligns with the family budget. So it would be good to investigate into this. These are the sort of questions you will ask further if you had the patient in front of you. And yes, we have Kalinda who has to do shopping on a strict budget because there are budget constraints in the family. And she works part-time at the Kunamula Hotel. And yes, and her shift is quite long. It's an 8 to 10 hour shift. And so yes, the other things you would check is, so what are the shopping and cooking arrangements? Does she do it, or does the partner help, or like what's going on with the shopping and cooking arrangements? All right. Then you have, it does not say with the part-time work at Hotel Kunamula that it's always hands-on and she's always on her feet and she's running about. It does not say that. So something like this you would investigate, because for instance, even I have a 8 to 10 hour work when I'm not teaching, but I'm in my office, but all I do is, yeah, I can't stand because I have a standing desk, but yeah, typically people would just sit for like, most of that time in that 8 to 10 hour shift. So that is something you would ask. And you would think that her job is not very physically active because she is currently experiencing a knee pain, and therefore it is difficult for her to increase her physical activity or to exercise and things because of the knee pain. So it is not wrong to assume with the limited information given in the case study that it's not a very physically active sort of a role. Like for example, when you had Raj in hypertension, he was always on his feet running around. So like, it was clearly written. Here we have knee pain, which is like a big barrier for her to do the physical activity. All right. Then what do we have? Then we have that, yes, she does consume alcohol, and that is after work with her colleagues. And how is her readiness to change? Not very ready. You would classify her in being in a pre-contemplation stage. She's not in a denial stage. That's why she's come to you. But she's not in a contemplation stage as well. Like, yes, okay, let me make a change. She's still sitting on the fence. So yeah, pre-contemplation stage. So yes, that's why it's 5 out of 10. And she is from an Aboriginal and Torres Strait Islander origin background. So you would be asking about any cultural specification for foods likes and dislikes, and also about how she would prefer the nutritional counseling to happen. Because similar to Indian culture, even individuals of Aboriginal and Torres Strait Islander community members from the cultural workshop that I attended, they advised that they would prefer having the counseling, say, with their partner or with their family members. So that is something to ask, whether like what would be most comfortable for her. Would she like to invite specific family members in the counseling or not? That is something to inquire. Then Definitely, the kind of statements which are written in your case study indicates that she has limited nutritional knowledge, because she is asking you that she cannot have fancy, expensive diets, special meal prepared because healthy foods are expensive. So yes, that is like her bias. She thinks that if she has to eat healthy, it has to be prepared separately from the other family meals, and that would become expensive. So those are the barriers which you would have to address in your nutrition counseling session. Then again, so she has definitely limited, like, food and nutrition knowledge. It's quite evident. And she's tried various types of weight loss diets, like all these fat diets like lemon diet and stuff like that. And yes, so she feels she's tried everything for weight loss and it is not working, and therefore she is quite hesitant to try what you will be saying as well. So yeah, so these kind of things needs to be addressed in the counseling part of the intervention. Okay, so now we go on to the anthropometry. She is 160 centimeter in height. Her weight is 98 kgs. Weight has increased by 4 kgs in the last 3 years. And what was her weight like in the past 1 year? So it was 94 kgs. And this was 3 years ago, prior to her daughter's birth. And she reports to have never been skinny as such. But yes, 94 kg is what her weight was before the delivery, and now it is 98 kgs. Okay, and the weight fluctuation, she has been fluctuating from 70 to 94 kg in the past 10 years, has tried all type of diets in the past 10 years, because yes, in 10 years time, when an individual's weight keeps on increasing from 70 to 75 to 85 to 90 and 94, people are desperate and they would try anything under the sun to bring down their weight. But yes, it has not been working till date, and today she sits at 98 kgs. Waist circumference, it is 87 centimeters, and according to your NEMO, just that the BMI document which you have for NEMO, this is classified as increased risk of chronic disease. Then we have current BMI, which is, yep, it's 38.3. And what does this mean? She's classified as obese according to the World Health Organization classification. And then you have adjusted body weight. Adjusted body weight, by now, everybody should know the calculation for adjusted body weight, because I think we have spent a good amount of time doing the underlying math behind it. Her adjusted body weight is 73 kgs. Okay, so that's very close to what she was 10 years back. Okay, but yes, this won't happen, say within 1 year, going from 98 to 73 kgs. It would have to be a gradual, slow process. Okay, because in that process, you want to lose, say, fat mass and not muscle mass eventually. Okay, so yeah, again, remember, guys, the idea about desirable body weight is something which you can use when you are working as a dietitian, where you want to see what is the patient's goal. Is it realistic? Is it not realistic? And this helps you to guide patient to set realistic weight goals in the future as part of your counseling. So this is just a personal FYI which I do in my practice, and therefore I have put it over here. It's not part of your exams or your assignments or anything. So there are no crazy formula calculation for desirable body weight. You just practically ask your patient where would they like to see themselves. Okay, so yeah, so that is what I would do with her. That currently she is 98. She has been fluctuating a lot. So where would she like to see herself eventually? What weight would be her comfortable weight? Okay, so yeah, that is just for your own personal counseling FYI, not for exams, not for assignments. Again, yes, repeating. All right, team. So now you have these parameters over here. This is what has been given to you in your case study. So cholesterol is within the range. Okay, total cholesterol. HDL is lower. So yep, needs to be higher. Then you have LDL. LDL is slightly higher. Then you have fasting blood sugar levels. Fasting, and which guidelines have I referred to? I have referred to the RSCPG guidelines. But yes, you can refer to your handbook because that's the only thing which is allowed in your exams. But yes, I refer to the RACPG because for blood parameters, guidelines which are produced for GPs, they are much more pedantic and accurate. And I like referring to blood sort of parameters for the GP guidelines, because that's what they do. GPs are all dealing with blood, so their guidelines are super accurate. So yes, in your placements and things, you can refer to these guidelines because you will have access to it. But for your exams assignment, just keep to your handbook because that is all that is allowed. But according to the RSCPG guidelines, so where does this sit? So you have fasting blood sugar levels is 6.7, which is between 5.5 and 6.9. So this indicates, according to this guideline, that diabetes is possible. And I have given you references to all of these guidelines in your that reference document. Okay, so yes, what is my interpretation? That diabetes is possible. Then your case study also says that she went for a oral glucose tolerance test, meaning she's had the sugar solution, and now after 2 hours postprandial is when they are going to check their blood sugar level again. They checked her blood sugar level and it is 8.2. So this sits between 7.8 and less than 11. This, what does this indicate according to the oral glucose tolerance test? That this is impaired glucose tolerance. So what is my confirmation for her blood results? That Kalinda has impaired glucose tolerance as per her OGTT results. Okay, so what is impaired glucose tolerance? Pre-diabetes. So she is at a very high risk of getting a full-blown diabetes. So yeah, we have to be mindful about her diabetes status in the future. Blood pressure, it is high normal. Okay, so again, this is from your handbook, not very good. Okay, because it's already crossed the normal range of blood pressure, which is 80 to 120, and now it is greater than 80 to 120, high normal. So again, she's so basically, what does all of this mean in conclusion? As I said, this semester you have learned a lot of conditions which are about lifestyle disorders like diabetes, obesity, cardiovascular diseases, things like that. So therefore, when you have diabetes, obesity, cardiovascular diseases, all of this clubbed together in one person, this is called as metabolic syndrome. So does she classify as having metabolic syndrome? Let us see. So her waist circumference, if you look at the reference which I have for the metabolic syndrome, if you there is a second table, table number 2, which gives you the waist circumference for Caucasians and for other ethnic population. So if you look at Kalinda's waist circumference, it is definitely higher. So yes, this is met. One indicator of metabolic syndrome is met. Then you have reduced HDL. All right, so but less than 1.3. What is hers? It is definitely less than 1.3. So she has a second indicator met for metabolic syndrome. Blood pressure, 80 and 130 and 85. So yeah, that is also met. So third indicator of metabolic syndrome is met, and you know that minimum 3 out of 5 indicator, meaning that yes, this is a diagnostic criteria for metabolic syndrome, and over here she has 4 of the 5 criteria which are met. So if you look at her elevated fasting glucose level, yes, it is elevated and that is met as well. We do not have triglyceride levels, but I would be quite surprised if they were not high, if you know the GP had tested for TG levels. But yes, she has 4 of the 5 indicators met. So meaning our patient over here, Kalinda, she has metabolic syndrome. Okay, she has definitely indicators of metabolic syndrome. She is on medication for depression, and the GP is considering that if the diet which you give her, if it does not help her with her weight management and things like that, gradually he may put her on cholesterol lowering drugs, lipid lowering drugs. Why? Because she has definitely dyslipidemia going on. All right. Oh, hang on. All right. Yeah. Triglycerides were not given. I thought by triglyceride was over here, but no, that is the indicator. Yeah. Okay, so yes, GP is considering she is not currently on medication for lowering her lipid levels, but this would be considered if Kalinda's health status does not improve. And as you know, according to the obesity guidelines, if an individual's weight starts coming down, for an obese individual, if their weight starts coming down, this would have a beneficial impact on their lipid levels as well. So yes, if we as dietitians do a good job with her and she's adherent to what we do, then she may have the possibility of not going on these medications. Family history: father has type 2 diabetes, mother has heart disease. Both of them are controlled by medications. So, yes, a very, very high risk of her being susceptible to diabetes and CVD and things like that. And even her bloods are showing that at a very young age of 26 years. Then what do you have? Then you have, yep, all of this is normal. There is no issue with that. Functional capacity, we know that her knees are hurting. She feels fatigued and lethargic and things like that. But yes, knee hurting meaning a very big sign that this would impair her physical activity levels. Psychological, we know that she is having medications for depression. So mental health and well-being is definitely something to consider in this case as well. Okay, then we go on to, I haven't done the entire thing, guys, because you can do that. Yes, guys, for a individual with who has come to you for obesity, what I would calculate, the most core nutrients that I would calculate is definitely food groups, definitely kilocals, and if your time permits, you would calculate fat and saturated fat as well. Okay. But yes, if running out of time and panicking in the exam and whatnot, I would at least do food groups and kilocalories. All right, for a obese patient, because remember what is obesity? Obesity is a fine equilibrium. It's a balance between energy intake and energy expenditure. How much you are eating and how much you are burning out. All right. So what does this mean? It means that how much of calories you are eating and how many calories you are burning out. So energy as a nutrient is very important for calculation when you have a patient who's referred to you specifically for obesity. Okay. So yes, just like hypertension, how sodium is super important for us to calculate. Similarly, for obesity, calories are very important to calculate. And yes, if time permits, please calculate fat and saturated fat. These are the tentative numbers that I have shared with you. So yeah, I think I have been on the screen enough for you to have an idea about what it is. I'll just take 2 more seconds so you can write down these numbers, and that will help you to compare. Oh, of course, this is pre-recorded. You can always pause. Sorry, guys. Okay. Yeah, that's me. I'm such a goofy person. Okay. All right, guys. So now we do the quantitative analysis. So yes, as I said that my focus in this case study is kilocals, and I have just focused on kilocals, and I have just done all of the investigation around calories. All right. Because as I said, remember, obesity case, patient referred to you for obesity, meaning it's a balance between energy intake and energy expenditure. So this nutrient is super important. So I've just focused on this one nutrient, but of course, you would be very right in calculating fat and saturated fat as well. Okay. So yes, with energy, I have chose to use Mifflin, guys, because the individual is obese. All right. And your NEMO guidelines and your PEN guidelines say that Mifflin is more applicable for population with obesity compared to Harris-Benedict equation and Schofield's equation. All right. So that is my choice of using Mifflin, because it's quite designed for, it's validated for individuals with obesity. Okay. So yeah, that was my reasoning behind it. So when we use Mifflin, here is her weight, and here is her height, and here is her age. And as you know that she's having a lot of, say her knee are painful, it's uncomfortable for her to do physical activity, stuff like that. So I have kept to a very low PAL level, which is just 1.3, which is classified as light in your Mifflin handbook. All right, and then what it comes out, what is my calculation? It is 2,322. Now again, you have the option of using either guidelines. Your NHMRC guideline says just cut down, say 2,500 kilojoules, and that is how it creates energy deficit, meaning less intake and more expenditure will lead to weight loss. Okay, so weight loss has a very simple formula. At the end, you start reducing intake, your energy expenditure will gradually increase, not just in terms of physical activity, but when your body sees, oh, hang on, she's like eating less. So, all right, let me start using the internal stores of fat and things which I have for generating energy. Okay, so I'm not just talking about voluntary activities like running, sitting, skipping, hopping, no, also involuntary activities. Okay, so you are trying to condition your BMR. And this is just as an FYI, guys, just as a uh, from the pathophysiology lectures that I used to take on obesity. Just like how you have muscle memory, like how you build muscle memory, how people going to gym and stuff, like they start building muscle memory. I won't go into the entire concept of muscle memory, but that is how your body needs to build a memory about weight. So yes, when people go on a healthy diet and things, they start losing weight, which is amazing. But your body then, once you are happy with the weight that you have after your weight loss, okay, then you need to maintain that weight for at least 2 to 3 years for your body to accept that, okay, this is my new weight and this is the weight which I want to be in. All right, so that is called as like your body memory. So there are several, like research articles on this, but of course this is not like an super evidence based concept of the concept of muscle memory and your body memory. But basically it takes 2 to 3 years for your body to recognize that new weight and to keep to that new weight. Okay, so that's why, like after weight loss, when people start eating all crappy food, why do they gain weight? Is because there is not enough body memory. Your body needs to recognize and accept that new weight, which takes a long time. Then there are a lot of confounding factors in that building your body memory. The younger you are, your body metabolism, the kind of metabolism, meaning ectomorphic, mesomorphic, endomorphic, things like that. A lot of factors that will determine how quickly you build that body memory. But yes, this is just an FYI I wanted to share with you, because this is a concept that I discuss with my patients. Once they have achieved their weight loss, they are very, very happy. And then, to like, before I send them off, before I graduate them, I give them this information so that they are mindful about this factor, that they need to keep to this weight for the next 2 to 3 years for that weight to become their own. Okay. All right. So yeah, coming back to your yes, your case study. So yes, then you have or else you can use the handbook. I quite like the handbook, particularly for cases which are referred to me for obesity, because it's very specific, where you know that 1 kg of weight loss in a fortnight, if you want this to be achieved, you need a deficit of 500 kilocal or 2100 kilojoule. I like fortnight because it goes with your guidelines of NHMRC that for the first 3 months, see your patient fortnightly. And also fortnightly is quite a decent time to see your patients, uh, overweight, obese patients, for weight loss and management, rather than 1 week, which becomes too early, and 1 month, which they may lose motivation. 2 week is like a good midpoint. Okay, so yes, when I incorporate this 500 kilocal deficit, it gives me 1822 kilocal. So ideally, this is what she should be having each day. How much she is having is 3677 kilocals. So what does this mean? 1800 kilocal is what she should be having. She is having 3677 kilocals. This is nearly 100% more than her estimated energy requirement. Okay. So yes, we have calculated the energy requirement recommended versus the actual intake, and it is 100% more than what she should be ideally be having. Okay, so this is like showing you an idea about what she should be having versus what she is having, and these are the guidelines which I have referred to. Also there in your that reference document. Then definitely you do a qualitative assessment. As I said, qualitative assessment, very, very important, guys, when you have cases with overnutrition. And in this semester, you have covered, except for malnutrition, obviously, you have covered. I think all of your cases are predominantly for overnutrition. Okay, so you wouldn't be surprised seeing a person who is, say, having hypertension and who's overweight and obese, like how we had Raj. Okay, but yeah, it all depends upon what is their referral for, what is their priority for. So yeah, that determines what you have to do with that person. So in hypertension case, Raj was obese according to the Indian BMI cutoffs, but we didn't focus on weight as our first priority. He has come to us with hypertension. His diet shows that he's having very high amount of sodium. When your diet is very high in sodium, so yes, you have to focus on that nutrient first when a patient is coming to you for hypertension. Okay, so it all depends upon what is the referral for and what is the diet and the biochemistry talking to you. Okay, so yes, this in this one I have done a diet quality analysis, and yes, a discretionary food very high, coming a lot from saturated fat, refined sugars, which we are not surprised of. Alcohol intake is within the recommendation, but do check if she's having alcohols even on weekend. In your case study, it only says yes after work with colleagues and stuff, so that is Monday to Friday, and she's working part time. What happens on weekend? Is she having alcohol on weekend, because that is a lot of empty calories and you would be accounting for that. Okay, what are the other type of nutrients which are very important to calculate in this case? Fiber, fat, saturated fat becomes very important. Okay, then you have your pests. So as you know from the last two tutorials or workshop, I have start teaching you all the PES statements that are related to one condition, because diabetes and say obesity, they uniquely have their own PES statements, and then help you identify which is the most appropriate one. So we are going to have the same exercise over here. So what are all of the PES statements which are related to energy intake, which are related to weight management? Okay, so first you have is excessive energy intake. Please look at the definition. Excessive energy intake that exceeds energy expenditure. So you need to have, say, some sort of a proxy indicator for energy expenditure. Are you having a proxy indicator for energy expenditure in your calculations? Yes, you are, because when you do Mifflin, you account for some level of physical activity, which is an energy expenditure indicator. Why do I call it as a proxy indicator? Because you're actually not measuring using a pedometer the exact physical activity output and stuff like that. This is like a proxy value. But yes, you have some sense around it as to what a sort of an expenditure are you putting into. All right. So you have some proxy indicator for energy expenditure. And over here, the definition says energy intake that exceeds energy expenditure. So we do have an indicator for energy expenditure. Okay, intake that exceeds energy expenditure, established a reference standard. So we do have reference standard. We have done the Mifflin calculation and we know how much he should be having, or recommendations based on physiological needs. Okay, that's fine. All right, so yep, so this is your first PES statement in your document. Then you have inadequate energy intake. Inadequate energy intake is obviously not applicable in this case. There is nothing inadequate about it. Predicted excessive energy intake. You don't have any prediction, because this is not like a clinical trial where a person is there in your trial and you're predicting that their energy will increase or decrease or stuff. So no, there is no prediction. Again, there is no prediction about suboptimal intake. When would you have these sort of prediction? For example, with suboptimal intake, if I know that the person is going to start chemotherapy, radiation therapy, and I know that this has such strong changes on the organoleptic sensory properties of an individual and their appetite and things like that. So I would predict that a person who will start chemotherapy will have a suboptimal energy intake. Does that make sense? So it is more for complex conditions. It is not really means applicable for you in this semester. Both of these are not applicable for you in this semester, to keep it simple for you. Inadequate obviously is not this case. Okay, then you have increased energy expenditure. where you have your resting metabolic rate. Now we are talking about resting metabolic rate, not about like you running and jumping. Resting metabolic rate more than the predicted requirements. What does this mean? It means that when you have your involuntary functions in the body, they start using up more energy. When do you see this? You see this when people are having certain complex disease condition, or else people have had certain unfortunate incidents such as burns. Okay, so when you have, for example, a patient with burns or with an accident, with trauma, they are in a highly catabolic condition. Catabolic condition meaning there is a lot of breakdown in the body. The body needs more energy to do all of the involuntary functions in the body. Okay, so this may depend upon disease condition, this may depend upon trauma, this may depend upon certain medications, which may increase their metabolism. All right, so it depends upon various things, basically. Okay, so increase energy expenditure, again, not applicable for you in this semester. So this and this is not applicable for you in this semester. What are you left with? Excessive and inadequate. Inadequate obviously is not applicable in this case. So when we look at energy balance, which is actual or estimated changes in energy balance, this is the only thing which is applicable for you. When we talk about energy balance, we need to have both things. We need to have both calculations with us. Energy intake versus energy expenditure. Okay, so we have both in this case. We have energy intake, okay, energy intake over here, and we have energy expenditure as a proxy indicator, and how much we should be having the recommended energy intake. So we have both of these parameters, and this is the one which is applicable in this case. Then you have in your PES document, you have these things, which is oral and nutrition support intake, actual or estimated food and beverage intake from oral diet or nutrition support compared with patient's goal. Now over here, you have two options again, inadequate oral intake. Again, not applicable in this case. There is nothing inadequate about what she's having. Okay, so then you have excessive oral intake. Yep, excessive oral intake is oral food beverage intake that exceeds estimated energy needs, established reference standards, recommendations. Okay, so over here, estimated energy needs does not talk about, say, energy expenditure, does not talk about PAL and things. All right. So yes, it wouldn't be applicable in this case because you can actually do PAL. You can have a proxy physical activity indicator in your Mifflin calculation. So this is a more accurate PES statement to use. Then in terms of hospital setting, which is the one which is used more frequently, you would assume that, oh, when we do ratio method, we don't really have PAL, like, we don't have any physical activity proxy indices. So it is okay to use this. But till date, from the evidence that I have reviewed, what I have gathered is there is no clear guidelines telling you to use this in the hospital. So what next do you do? When you look at the NHMRC evidence, when you don't have strong evidence out there, you go on clinical consensus. What is clinical consensus? People who have been actively working in the hospital setting within this space, I speak to them and I ask them their opinion. So I had a chat with Emily and a couple of other dietitians who are working in the weight management area in the hospital setting, and I asked them, which is the PES statement that you use for overweight and obese patient if they are in the hospital setting? Do you use excessive oral intake or do you use excessive energy intake? They said that in the hospital, we will use excessive energy intake if we have calculated the energy requirement versus the energy intake. So this would be done using NEMO for an inpatient, and you would have the actual intake. If you have both of these parameters, if you have some sort of energy calculation, they then tend to use this one. Then I asked them, when do you use this one then? In the hospital or something like that, or even like wherever, when do you use this one? Because even in outpatients, We can definitely calculate energy expenditure as a proxy indicator using PAL. So we know this is definitely 100% relevant for outpatient. In inpatient, the dietitians have advised they again use excessive energy intake as long as they can calculate energy recommended intake versus energy, the actual energy intake. Okay. So I'm just summarizing this again for you to make it as clear as possible. So yes, I asked the dietitian, when do you use this one? They said, when you have not calculated energy as such, there is no quantitative analysis done. When you have certain circumstances in which no quantitative analysis has been done, so this section is not there at all, and they have only done a qualitative assessment. They are having more junk food, they are having less veggie, they are having more refined cereals, stuff like that. So it is only talking about oral intake. It is only talking about oral intake in comparison to a reference standard. What is the reference standard over here? It is the Australian Dietary Guidelines. Okay. So you have oral intake, what they're having. Qualitatively, they're having more junk food, more refined sugar, and stuff like that. And this is compared to a reference guideline, which is Australian Dietary Guidelines. Okay. So when you just have information on oral intake and you actually cannot calculate a person's energy requirement, that is the case when you use excessive oral intake only, when you can only do a qualitative analysis. Whenever you have the opportunity to do a quantitative analysis, okay, be it via outpatient calculation, which is Mifflin or Schofield, or be it via inpatient calculation, which is the ratio method, please use excessive energy intake. I hope that is very clear. When you can calculate energy recommended versus energy intake using any possible method, inpatient or outpatient, use excessive energy intake. When you just cannot calculate energy for some reason, all right, it's not there, like, means that information is not there. Patients, say for example, patient's height, weight, age, whatever is not given, you just know that the patient is overweight or obese, and like some random incomplete data situation that you have. Only in that case, when you can only do this sort of a thing, qualitative analysis, okay, that is when you do the excessive oral intake, only that time. Okay. All right, so I think I have spent enough time in explaining to you when you use excessive energy intake. You use it both for inpatient and outpatient. You use it whenever you can calculate energy recommended versus energy intake. All right, so I hope that is crystal clear, guys. And now I'll move on further. So now we have our PES statement. So what is our problem? Excessive energy intake. Why are we using this? Because we have a proxy indicator for energy expenditure, which is your PAL, which you get from your Mifflin equation, and you have calculated energy recommended versus energy intake. So you're using excessive energy intake. Excessive energy intake is more superior and accurate compared to your qualitative excessive oral intake. Okay, so wherever possible, try to be more accurate, which you are in this case. Then you have cause. What is the cause? Definitely 100% food and nutrition knowledge deficient, because she's been following those crazy diets, and she's telling you not to, she doesn't have money for fancy food and stuff like that. So definitely she needs a lot of support and a lot of intervention in terms of her knowledge space as well. Okay. What is the evidence? Evidence is energy intake is 100% more than the estimated energy requirement. All right, so when I have a statement like this, I cannot have oral intake over here. Okay, I need to have excessive energy intake because I have calculated energy intake versus recommended. Then you have discretionary food choices. Then you have BMI, so she's obese class 2. Then you have waist circumference, and then you have indicators of metabolic syndrome. So all of this is evidence for your PES statement. Okay, so I have one clear-cut PES statement. Okay, now what we do is intervention. So guys, in this intervention, Marie Claire has advised me to give you a bit more guidance about intervention because some of you are still not getting a hang of it. So I have written this intervention in the exact 4 subsections that you have in your handbook. So I have designed this intervention according to food nutrient delivery, nutrition education, nutrition counseling, and coordination of care. Okay, so we just have one PES statement and we are addressing this one PES statement in our intervention. So it's a very strong clinical link, but I have divided your intervention in the 4 clear subsections which are there in your handbook. Yes, Marie Claire said that students are basically confused about goals and strategies. What is the difference between goals and strategies? But I thought I'll explain this to you by showing you a clear cut breakdown for your entire intervention, like, the way I would write it if I was doing your exam, sort of a thing. What are goals? Goals are designed for the dietitian. I'm a dietitian. This is the goal which I have for my patient. My patient couldn't be bothered about my goal. This goal is for me. This is the goal I want my patient to achieve. Okay. But this is too technical and fancy for the layman patient. They are not bothered about this, your fancy, complicated, clinical sounding goal. So please remember, goal is for the dietitian. Goal is written in a smart format. Goal is therefore this goal which you have for your food and nutrient delivery, therefore is a very complex goal which is designed for you. This is, you are telling yourself this is what you want for your patient. What is strategy? Strategy is what the patient is interested in. Patient has come to you for a consultation. Patient is interested in, like, if I was a patient, I would tell you, okay, tell me what I need to do in my diet, in my breakfast, in my lunch, in my dinner. They just want to know what they need to change in their diet. So strategies are all take home messages. Strategy is patient, goal is dietitian. Okay, so goal is dietitian, strategy is patient. Strategy is all about you telling your patient, you do 1, 2, and 3. At the back of your mind, you know, if your patient does 1, 2, and 3, this will help you to meet your goal for the patient. Does that make sense? Okay. Okay. So yes. So what is the goal which I have over here? Decrease daily energy intake by 500 kilocal. Why do I say this random 500 kilocal? It is not random because I know your handbook says that if I want my patient to have 1 kg weight loss in a period of 2 weeks, this patient needs to reduce her calories by 500. Okay. So yes, therefore my goal is for her to decrease her kilocal intake by 500. How much is she currently eating? She is having 3,677 kilocal. She needs a deficit of 500 kilocal. So that is, what does this mean? It means like 14% is what we are reducing from her actual energy intake. Okay. So this is my goal for her. If I tell her this, she will just walk out of the room. She'll be like, what is it? What are you talking about? Okay, so this is too fancy, too complicated. But if you see this is a SMART goal, this SMART goal is for you as a dietitian. Is it SMART? It is specific. It's very, very specific. I have what makes a goal specific when you put in actual numbers, okay, and time frames. Okay, so it is very specific. My number is 500 kilocal reduction, which is 14% of her total energy intake. Okay, and this will give me 1 kg weight loss. So it is very smart, it is very specific, it is very realistic as well, because it is not I'm telling her to reduce 1 kg in like 5 days. No, it is over a period of 2 weeks. So it's very realistic. Is it time bound? Obesity is the case where from the NHMRC guidelines, you have this period of 2 weeks. So definitely it is time bound. So you have 2 references over here. So you have NHMRC, which is the 2 weeks. So obesity is a great case where NHMRC gives you a very specific timeline. Okay, and your handbook also gives you a timeline. All right. So yep, we want the patient to reduce their weight by 1 kg in 2 weeks. So you have it's measurable, it is time bound, it is very specific, and it is very realistic. So it's met all of your SMART. Okay, now what are the strategies for her to reduce 500 kilocal? Well, I'll be telling her that in breakfast, she has a thick spread of butter on toast. But I know that when she's having her lunch, she does have a thin spread of butter on her sandwich and things. So she wouldn't be very against this goal. So I have told her that in breakfast, please have thin spread of butter rather than thick, thick spread, not thin spread. Okay, so have a thick spread, have a thin spread of butter rather than a thin spread of butter on her toast. Okay, so that's her breakfast strategy. This will give me a reduction of around 66 kilocalories. Okay, around. Then cooking method, use half of the fat that she's using for cooking. Use two teaspoons instead of 4 teaspoons. So very small little changes. I'm not saying don't use fat at all for your cooking. Don't use butter at all for your bread. Okay, so it's not like that. It's not unrealistic. It's a moderate change, slowly but surely. This will give me a reduction of around 71 kilocalories. Then switch to light beer rather than regular beer. This will have a reduction of 104 kilocalories. Switch to sugar-free lemonade rather than having the regular lemonade, which is again a reduction of 281 kilocal. I add all of this up. This gives me a reduction of 522 kilocal. What did I want her to reduce? Around 500 kilocalories. Okay. So this is the sort of a change that she should be making. She can start. Then let's look at nutrition education. I'll take it step by step. Nutrition education, you have to give her healthy eating resources, NEMO resources, definitely ideas upon cheap and healthy budget-based recipe ideas, resources for that as well. Diet disease relationship, very, very important because she has very poor nutritional knowledge, has been following fat diets and things. Healthy diet is expensive and all. So you definitely need a good talk about diet disease relationship. All right, what fat diet does on the body and how healthy food does not need to be expensive. You can have healthy food, but it can be on a budget as well. Stuff like that. Nutrition counseling, I would use the trans theoretical model for her nutrition counseling because she definitely is in a pre-contemplation phase. This is the goal setting for your patient. Okay, this goal setting is very different from your food and nutrient delivery goal. Does that make sense? In this goal setting for your patient, I would tell the patient, look, I have told you to follow 1, 2, 3, and 4 things. Okay, you start doing one change each day. Day 1, you do the bread. Day 2, you do the bread with cooking method. Day 3, you do the bread cooking method, and that day with your colleagues, you will be having a light beer. Day 4, try to do these 4 changes and see if it is working. Okay. And if you keep doing these 4 changes for a period of 2 weeks, every day you will be having a reduction of around 500 kilocalories, and this will gradually start making a difference to your weight. Okay. So this goal setting is very, very different from this goal setting which you do for yourself as a dietitian. I hope this has made it very crystal clear. Okay, so yeah, this goal setting this is what I would ask the calendar to do. Definitely maintain a food diary. And when you have achieved this one thing, reward yourself, not with a chocolate cake. Okay, please. Of course, I wouldn't be using this attitude and this face when I talk to her. But yeah, non-food rewards. Okay, so like, yeah, means, yes, you can, I don't know, think about non-food rewards. Right now my brain is not working for non-food rewards, but there are so many non-food rewards, like does not have to be going for a shopping spree all the time because she's on a budget. We have to be mindful about that. Even like watching, a good movie or something like that. Or yes, like, doing yeah, like, doing something special for yourself that weekend. Yes, maybe a nice facial or something. Okay, so yeah, some good non-food reward, whatever she likes. You will be asking her what she likes. I won't say facial and then she says, I hate skincare. Okay, so no. You'll ask her what are the other things she likes doing, and she can do that as a hobby. Then coordination of care, definitely her knees are hurting. I would definitely refer her to a physical activity expert or a exercise physiologist, something so that she gets help with her knee. If I don't refer her, I would definitely ask her to speak to her GP about this, so her GP can refer her to the appropriate person. If you feel that by the next visit, she still is in that pre-contemplation phase, she hasn't really followed all of these changes, and she still has a very negative attitude, meaning she needs support and guidance for her mental health, and then you would refer her to her psychologist or refer her back to her GP, talk to her GP so that he can refer her to the psychologist if you do not have everybody's detail. Like obviously you may not know everybody, all of the other allied health professional as an outpatient private practicing dietitian. So this is what you can do. Monitoring evaluation is very simple, ABCD. So A is definitely check up on her weight, waist circumference. Again, a lot of the time, this is again from pathophysiology point of view. If waist circumference, for example, waist to hip ratio is a stronger indicator of body of adiposity compared to weight. What is adiposity? It is the actual fat, like in your body, all right, and the fat around your visceral organs and all of that stuff. If the waist circumference is going down and maybe the weight is not going down, still that is a very positive indicator, and I would encourage and I would congratulate Kalinda that her waist circumference is going down, because research has shown waist circumference is a stronger indicator of adiposity, meaning her fat is actually decreasing. Your weight is an indicator of both lean body mass and your fat mass. Waist is more of an indicator of a fat mass rather than a lean body mass. Okay. So yes, so that is very important. See if she's comfortable and she allows you to measure her waist circumference again. A lot of time they may not be comfortable, but you may tell her the importance of it, and maybe after second or third consultation, they themselves may say that, oh, can you measure my waist? Or they may do it, say at home, and they would find it encouraging. So a lot of the time, guys, if you convert the sciences in simple language for your patients, they get motivated to do it. A lot of them, a lot of the patients which I have seen in my career, they tell me that, thank you so much for telling me what is happening in my body. And now I know why I'm doing what I'm asked to do. And they have clearly told me that a lot of dietitians that they have gone to, the dietitians just tell them this is what they need to do, but they don't explain why they need to do it. So converting that science in simple language, that diet disease relationship communication is so very much important. Of course, the skills will be strengthened for you in your second trimester. So don't worry, it will happen with time. You will become stronger with that. But yes, okay. So I'll move on now. All right. So it's so weird, right? If you just talk to yourself like this. Okay. So then you have biochemistry. I would check all of her blood levels again. Of course, the GP will, she may visit you after 2 weeks, but that does not mean that the GP will order the blood results after 2 weeks. There are certain things with Medicare that they have to follow, when it will be covered, how it will be covered. So you may get the blood test later, but yes, that is something which you will keep a tab of, that you will consult with the GP when is her next blood test due. Okay. Then you will check for her blood pressure, knees, fatigue, lethargy. All of that is something which you will check for. Check for any change in medication, because she is on medication. If she does not know all of that things, please have a chat with GP, get updates from GP. Check if she's adhering to your dietary regimen. All right. Identify if why she's not adhering to her dietary regimen. Is this 4 things really tough for her? Or is it like still she's in a pre-contemplation phase? She's not motivated to follow your changes. Is it depression that is actually hindering the dietary intervention? So check for all of these things so that you can, like, do appropriate referrals. Referral definitely would be for a psychologist, as I said. It could be for a physical activity expert as well, because for the knees, all right. And you know that the guidelines have said that this is your NHMRC guidelines, which is fantastic because it has an exact time frame for obesity intervention, which is what I love, which you don't have for other guidelines like your CVD and diabetes, which is a shame. But we have something over here which says that arrange fortnightly reviews. So see her after 2 weeks, so that 1 kg weight loss is a realistic thing for the first 3 months. And then you can see her monthly, maybe, and then the monthly will become 6 weeks, and then it may become 8 weeks. for at least 12 months. Okay, so yes, this is a good time frame which you have from your obesity guidelines. But yes, guys, this is all that I wanted to cover for you for this workshop. And I hope the pre-recording will help you.